scope for the want to set the scope for the types of use cases for machine learning and AI in healthcare that I'll discuss in this talk. I'll primarily be discussing what we might think of as applications of supervised machine learning to diagnostic and prognostic use cases. So this is sort of, use cases that we might think of as being kind of in the pre-LLM or generative AI craze of the last few years. And so an example of a diagnostic setting would be one where it is of interest to identify the presence of a radiological finding from a chest X-ray. An example of a prognostic setting would be one where it is of interest to predict whether a health outcome occurs at some point in the future. So for example, you can imagine a model that predicts whether a patient would develop a cardiovascular event, let's say in the next 10 years, or whether a patient in the ICU would be likely to die during their hospital stay. And so an important part of this overall objective is to say that we're trying to understand how to design evaluations of machine learning systems that are appropriately grounded in the context in which they are intended to be used. So this requires shifting the framing from thinking of machine learning systems as simple models for classification and prediction, but rather as interventions embedded in socio-technical systems that involve complex and dynamic interactions between people and technologies. So at a minimum, this means that we need to be clear about how a model is intended to be used and who will be affected by any of its potential benefits or harms. And ideally, we'd like to be able to translate statements about model performance into contextualized statements about the downstream impact of the model in its deployment context. So for example, if we're talking about a classifier that is used to identify different types of radiological abnormalities in chest X-rays, we might want to define how that model is used in clinical workflow. So for example, as a diagnostic or a screening mechanism, for which populations it's intended to be valid for, and what the impact of different classifications are on the downstream health outcomes for patients, and what impact that might have on health outcomes and disparities. So another piece of this is that we need to address the data used for model development and evaluation reflect complex societal contexts that include structural racism and other social and structural determinants of health that contribute to disparities in health outcomes and also contribute to disparities in access to care and care quality. And so an important implication is that the data used reflects both population-level differences in health, directly implied by the presence of health disparities, as well as systematic differences in the representativeness of that data across populations. So for example, due to differences in access to healthcare across groups. And something that's important is that these two sort of categories of issues have different implications for how we interpret our model evaluations. And we'll dig into implications of both of these factors later in the talk. So to provide an overview of where we're going to go from here, in the first part, I'll focus on a setting where we're sort of assuming that we have access to a large and representative data set and that we've sort of formulated our problem in a way that is reasonable for our use case. And then I can show how we can reason about the performance of predictive models in terms of decision theoretic properties defined over that defined use case and target population, which provides some means of sort of connecting our prediction problem to sort of the intervention context. And then even if we've sort of done a good job at that, I'll discuss how some simple yet counterintuitive properties of really just of performance metrics can render some evaluations misleading when we're interested in trying to assess something related to fairness. And finally, we'll shift our attention to effects of upstream biases related to systematic differences in the representativeness of data across subgroups, specifically label bias due to proxy outcomes, as well as forms of selection bias. And throughout, I'll discuss how causal modeling provides a means to sort of formally ground our evaluations in the sense that it gives us tools for formal specification of domain knowledge and assumptions. And so to begin, as I mentioned, we'll focus on issues arriving in what I'm calling the well-specified setting and discussing sort of basic disaggregated evaluations across subgroups. And that is evaluations where we're evaluating a model across a collection of subgroups of the population. And so as I mentioned, this is a setting where we are assuming our data is actually representative of the populations that sort of compose our target population. However, in this setting, it is still the case that the distribution of data differs across subgroups in that health disparities are likely to imply different population level distributions of outcomes and clinical covariates. And so in this paradigm, the standard approach that folks have taken in the community is to compare the value of some metric, such as a model performance metric, across the subgroups, perhaps taking differences in that metric across groups to indicate unfairness. So for example, you might ask the question whether the model is more accurate for one racial or ethnic group versus another. And so to provide a more complete picture of this paradigm, I'll introduce a few more concepts using some simulated data. And so here we're plotting what are called score distributions. And so let's just focus on the top left plot for the moment. And so to construct a plot like this, you can consider a predictive model. It outputs some continuous valued score between 0 and 1 for each patient in a subgroup or a population. And so the distributions at the top left under the header unconditional are then essentially the distribution of those model outputs for two groups in purple and orange. And so to use the score for classification, one could compare it to a threshold. And so then the fraction of each population classified as positive under that threshold rule is just really the area under this distribution to the right of that threshold, which you can get at using the cumulative distribution function. And so if we compare, we think of it as the classification rate across subgroups, which is just the fraction classified as positive, we can see what that comparison would look like for any given threshold in the bottom left plot. And so this corresponds to a notion of fairness called demographic parity or statistical parity. And so we can also imagine taking the population and visualizing these distributions of scores conditioned on sort of the value of our outcome y. And so that is separately for those who the ground truth labels have been assigned as negative or positive. And so what's kind of interesting here is that the false positive rate is actually just the area under the curve to the right of the threshold for this y equals 0 distribution. And then similarly, we can get the true positive rate in sort of an analogous way for the y equals 1 distribution. And so because of this, it's sort of common to reason about fairness in terms of differences in these rates. So that would be differences in specificity or sensitivity across groups, or recall or true positive rates, false positive rates. You can use different words to refer to the same thing. It's common to sort of reason about fairness in terms of the difference in those rates, and then also in terms of differences in terms of these distributions. And when these distributions are sort of the same distribution across groups, we'll say the model satisfies separation. And when it satisfies equality in the rates, we'll call it equalized odds. And so another concept to introduce is the calibration curve. And so here we're plotting curves for 3 different subgroups. And on the x-axis, we plot the value of some score. And on the y-axis, we plot the observed incidence of a positive outcome conditioned on the score, meaning that for any given value of the score, we're sort of plotting the fraction of the population whose label was actually positive. And so for the group represented in purple, the model is perfectly calibrated, meaning that the conditional probability of the outcome for any given value of the risk score is the value of the risk score itself. And so for the group in green, yeah, sorry.
Sorry, I think that was somebody who wasn't on mute.
No problem. Yes, as I was saying, for the group represented in green, the model is actually overestimating risk of the outcome because for any given value of the score, the observed incidence of the outcome as indicated by the calibration curve is sort of lower than the score. Analogously, the risk is underestimated for the group in orange. And so these curves can be useful for reasoning about fairness decision-making in a very specific way. So for example, if the intention is to screen patients whose risk of some condition is greater than 20%, we can see that a screening policy would effectively refer patients in the green group whose actual risk is lower than 20%. And in the orange group, there would further be some patients whose actual risk exceeds 20% that are not referred, such that patients would need to be effectively at some risk greater than 20% in order to be referred by the screening policy. And so you can think about this form of differential miscalibration as effectively implying different implied thresholds across groups, even if you sort of pick the same threshold. And so related to these ideas is a notion of fairness called sufficiency, which essentially just requires that these 3 curves be the same. And this can also be useful for reasoning about sort of the statistical optimality of predictors, just in the sense that calibration, statistically optimal predictors are calibrated, even if calibrated models, or even if not all calibrated models are optimal. So this implies that if we see miscalibration, we sort of know that the model in some sense could be improved. And so there's some well-known kind of relationships between these different criteria. And I'll try to dig into some of these relationships here. And so here we have 3 rows corresponding to these different notions of fairness that I just mentioned. The first row corresponds to a case where the model is calibrated for each group, but the score distributions are not the same. In the second row, we have a case where it sort of satisfies demographic parity. So we have the same score distribution for each group, with sort of different calibration curves and, again, sort of the same ROC curves that we saw for the calibration case. And then in the final row, we have a case where the model satisfies separation, where essentially the ROC curves have been projected onto one another, which induces miscalibration and actually just introduces a very slight perturbation to the score distributions. And so one issue is that, or that I've seen, is that there are many works that essentially choose one of these different approaches to thinking about fairness almost arbitrarily, without real grounding in the context that they're working in. And so what I had sort of aimed to do through some of my work was try to understand how we can use kind of the properties of the deployment context in order to sort of let's say, come to a value judgment about which of these is most appropriate in different contexts. And so to get insight into that question, I'll introduce a pretty simple framework for reasoning about model evaluation in terms of downstream context, sort of built on some sort of standard medical decision-making theory. And so to begin, in the most simple case, you could assume something like a simple utility or cost function, where you have some fixed value associated with each cell of a confusion matrix. So that is for each of a true positive, false negative, or true negative. This then allows us to define something called the conditional utility, which is just the expected utility associated with allocation of the intervention for an individual that the model gives any value of the score. So there's sort of 2 components to this, which we index here by 0 and 1, which just correspond to essentially the expected benefit of allocating an intervention and also of not allocating intervention. And then we can define sort of an overall measure based on their difference. So the intuition to take away here is that a patient would prefer to be treated or to receive our intervention if they expect that they would be better off if they received it than if they didn't. And so that's when this basically whenever this difference UConn, which is UConn 1 minus UConn 0, is positive. And another piece of intuition here is that if you imagine that this function is sort of monotonically increasing, you could sort of pick a threshold such that everyone above the threshold would prefer to receive the treatment and everyone sort of below the threshold would prefer to not. And so you can actually sort of directly derive what that threshold would be for a calibrated model here at the bottom of the slide. And one thing that's interesting about that is that it is only a function of these assumed values associated with the different cells of our confusion matrix, and sort of not a property of really anything else of the model, as long as we assume it's calibrated. And so to visualize this, so on the slide, we assume a calibrated model and assume a simple set of values on the right-hand side and plot these conditional utility functions. So in red, we have the conditional utility of no treatment, and in blue, we have that of treatment. And you can sort of see that there is some point where they intersect, which is 0.2. And that's the same point where this black curve, which is their difference, sort of crosses 0. And that this value here is exactly what we expect based on the assumed values that we put in the matrix on the right. And so I also want to note that this type of analysis does actually extend in certain ways to sort of more complex assumptions on how we think about like the treatment effect of the model. And so this is an example where we're assuming sort of a prognostic modeling context, and we have an intervention that essentially reduces the risk of the of some health outcome. And so, for example, our intervention could be to prescribe a statin to lower a patient's cholesterol based on an estimate of the risk of developing cardiovascular disease in the next 10 years. And then the conditional utility is then defined in terms of prevented cardiovascular events. And so without going into too much detail here, we assume that there are some potential side effects or harms of that intervention that would imply that patients with low risk would prefer not to receive that intervention, but that these are then outweighed by positive benefits of reducing risk when risk is high. And so similar to the previous slide, we can see that this induces this sort of positive monotonically increasing conditional utility function on the right-hand side, which allows sort of a similar type of reasoning about threshold setting. And so to sort of bring this home, we want to be able to say, okay, for a given level of model performance, how can we sort of translate that into a notion of clinical benefit? And so again, we can sort of use existing metrics from the medical decision-making literature to do that. And so on the top, I'm showing what's called aggregate utility, which is just sort of the total utility that a population or subgroup would receive on the basis of an allocation of intervention for a given threshold. And so the main difference between this measure and the ones I showed in the previous slide is that this one depends on the distribution of that score, whereas the previous one was defined just sort of conditioned on the score. And so as you can see, this kind of produces a somewhat unwieldy expression. And it's maybe not as useful as we'd like because it requires actually specifying these different utility values. And so there's a trick that comes from this literature that allows us to define something called the net benefit, which takes the same optima as that aggregate utility without actually requiring us to specify those utility values. Instead, we actually only need to specify what is this threshold for which, sort of based on our knowledge of the system, that we would prefer, or rather that patients would prefer to be treated above that threshold. And so you can see this expression for the net benefit in the middle of the slide. This is actually just a scaled and shifted version of the aggregate utility above. The details aren't super important, but the main intuition is that we can divide through by UTP minus FN and then subtract off some constants, and then we get off this net benefit. And you can see that this is just a scaled, or this is just a weighted combination of sensitivity and specificity with weighting that depends on the outcome prevalence and this optimal threshold, which you can think of it not so much as a threshold, more so than a statement of the assumed preferences for different types of model errors. And so in my 2022 fact paper, we took the stance that, or rather we considered a fairness criteria that was based on trying to have a policy that, let's say conferred the most benefit possible simultaneously for all subgroups. And so notably in this case, there's actually no fundamental trade-off between predictive performance and fairness in the sense that it essentially couples the two things together. And so what we find is that if you assume that the different subgroups sort of have the same preferences for a different outcome, or for, so let's say those different cells of the confusion matrix, that's for true positive, false positives, false negatives, true negatives, a model that is calibrated and satisfies sufficiency, that is, that it's calibrated for all subgroups, or rather has the same calibration curve, is actually consistent with a policy that confers the most benefit for each subgroup. And so the way you can see that is here we're plotting that net benefit metric I showed earlier with sort of a fixed assumed optimal threshold of 20%. And so what we can see is that if we pick that threshold of 20%, we sort of maximize that net benefit simultaneously for all subgroups, even if that value is sort of not the same for each subgroup. Conversely, in the other cases, so in the demographic parity case, for example, if you pick a single threshold at 20%, you sort of maximize it for the purple group, which is the one that was calibrated. But then the optima is sort of at some other point for the other two groups. And what you'd find is that if you sort of adjusted your threshold to account for that, you would effectively just be undoing the miscalibration. And then on the, you also see that there's a similar sort of effect for the separation equalized odds case. So, this is, again, I think, actually a somewhat well-known set of trade-offs that folks in the sort of methodological algorithmic fairness literature have been describing for a while. But I think that there's actually sort of a more general phenomenon that I want to talk about here, which is that of confounding in fairness assessments. And this provides sort of an alternative lens to understanding some of the issues we just discussed. And so the basic issue at hand is that if you've sort of committed to the problem formulation of prediction, and you're interested in measuring like model accuracy overall and over subgroups, we have the problem that that model effectively can be simultaneously optimal for all subgroups, in the sense that it cannot be improved through additional data collection, and yet obtain different average performance for those subgroups. And so this does imply that those assessments could be misleading in some cases. And so what I want to convince you of is that this phenomenon can be understood as sort of a direct consequence of these structured differences in the data distribution across subgroups, which are expected when we do have disparities. And I'm still differentiating this from a setting where we can think of the data collection process as being misrepresentative or biased. And we will loop back and bring that in later in the talk. So to make some of these points rigorously, it's helpful to introduce causal directed acyclic graphs, or DAGs. And really the purpose of these is to describe assumptions on the role of subgroup structure on the data generating process, and then later measurement mechanisms. And so one key point I want to highlight is that these graphs allow us to encode our assumptions about which relationships are assumed to be sort of stable or different across groups. And so here's a couple set of graphs, and we'll assume there's some set of covariates X, so these that indicate medical history. So this include things like diagnosis codes, lab test results, and so on. And then in a prognostic setting, we might think of predicting some future health outcome Y. And so here we'll say that Y is the true label of interest for prediction. And then this directed arrow from X to Y encodes the assumptions that the covariates X are the causes of Y. And so we'll use A here to indicate subgroup membership. But I want to emphasize that I do not consider subgroup membership A to be a direct cause of any of the other observed variables. Instead, we'll use these bidirected edges to indicate the presence of an unobserved cause of X that differs in distribution across subgroups indexed by A. So for example, if A indicates patient race, bidirected edge between X and A would indicate differential exposure to structural racism across racial groups that causes racial health disparities and thus differences in population health. And then on the right-hand side, we can also consider sort of an analogous bidirected edge between A and Y, which would indicate some similar effect, but one that induces sort of a difference in downstream outcomes across subgroups that's not accounted for by X. So for example, if we're considering a process that takes place over time, some differences in access to high quality healthcare after some point in time at which X is measured can lead to differences in the actual values of that outcome due to differences in care received across groups, even after we sort of account for X as like a set of baseline covariates. And so at the bottom, we note some important properties in these two settings for prediction of binary outcomes. And on the left-hand side, I guess just to summarize these, I'll note that the optimal prediction of Y from X in the left-hand graph is calibrated for all groups and also satisfies sufficiency. And on the right-hand side, because of the presence of this edge between A and Y, you'd find that if you sort of fit that optimal predictor, just using the covariates X of that model will not be calibrated or will not necessarily be calibrated for subgroups. But if you were to fit a model that sort of uses subgroup information as an additional predictor, or by sort of fitting a separate model for each subgroup, you would have those properties. And so I'll note that these graphs have been used quite a bit to describe the behavior of machine learning models under distribution shift. And so the two graphs discussed in the previous slide are analogous to those in the first row here. And we can call those the causal direction because the Y outcome is causally downstream of our covariates X, as in a prognostic context. And the bottom row shows the anti-causal setting. And this is where we might think of as the covariates X as being downstream of the label Y. So this is typically thought of as more appropriate in a diagnostic setting where we can think of covariates as sort of the presentation of a condition that is either present or absent at the time of prediction. So for example, if we're thinking about chest x-rays, we might think of pneumonia as Y and the sort of the presentation of pneumonia in the x-rays themselves. And so for example, we can use these graphs to reason about distribution shift. So in the top left graph, which is this covariate shift graph, we're sort of assuming that the mechanism that generates Y from X is the same for all subgroups, but the distribution of X differs across groups. And then in the outcome shift graph immediately to the right of that, we're assuming that mechanism by which A and Y is sort of generated across subgroups differs, but the distribution of X is the same across groups. And the complex shift graph just sort of takes both of these things into account. And then for the anti-causal graphs in the bottom, the label shift graph sort of encodes the assumption that presentation of our condition is the same across groups. So if you have a set of patients with pneumonia, the presentation of those X-rays sort of has the same distribution across subgroups, and similarly for non-pneumonia cases. And then this graph encodes the assumption that just the prevalence of that outcome changes across groups. And then the presentation shift setting is sort of the other side of this, which is to say that we're assuming that the presentation of the condition would change across groups. And so you could think of this as maybe a case where there's some systematic difference in the different scanners that is being used to measure the chest X-ray across groups, which could be due to confounding with sort of the hospitals that folks are going to. Okay, so analysis of these causal graphs actually allows us to like immediately read off certain fairness properties. Here, assuming that we are, again, talking about these sort of optimal predictors. And so what we can see is that when we talk about sufficiency, which is that equal calibration curve condition, and we fit a model using just X, so that's here, this is E equals X case and on the left-hand column, we'll see that we expect sufficiency to be satisfied under the covariate shift graph and then not under other graphs. And then when you use sort of X and A for prediction, you actually expect sufficiency in all cases. And we talk about separation, which is that condition that essentially controls those conditional distributions that give us equal error rate control. We'll see that we sort of only get separation under the label shift graph, and then only if the prediction depends only on X. In any other case where you sort of fit them both X and A, you actually don't expect sufficiency to hold. Except one caveat here is that I'm sort of reporting on sufficient conditions, which means that these are settings in which the structure of the graph implies that the property holds when the check mark is there. But then when there's an X, it's still sort of possible it may still be possible to construct a distribution that satisfies the fairness metric or the fairness criteria. It's just that it's not constrained to necessarily be satisfied. So just to summarize a few of these properties again, the main thing to note is that under covariate shift, we can think of subgroup agnostic prediction as generalizing in the sense that one model that you fit with X is actually sort of the same correct model for all of our subgroups. And that model is also calibrated for subgroups. And then this is generally not the case if we assume some other graph. And then you can also think about this in terms of whether subgroup membership is sort of informative about Y given X. And I say informative sort of in the statistical sense. And then, however, in neither case do we generally expect performance to be equal across groups. And so I also want to briefly mention a special case here that behaves very differently from anything we've discussed so far. So this is the case where the subgroups are separable, meaning that it's possible to predict subgroup membership with high accuracy from the data. So the interesting thing here is that the Bayes optimal model that predicts based on X alone actually behaves as if it's subgroup optimal, which basically means that it behaves as if the covariate shift assumption holds regardless of the underlying causal structure. And so the intuition for this is that the covariates actually hold all the information about A. And so prediction using X alone is actually essentially equivalent to using subgroup membership directly from the perspective of the model. And so this actually implies that models fit in this setting satisfy the properties we've laid out thus far with regards to the covariate shift assumption and its impact on expected fairness properties. And so to test some of these properties, we conducted a simulation study with data generated from each of the causal graphs discussed so far. And so we include one additional setting that sort of corresponds to that separable case, which is sort of in the middle of the slide. And so in the first row, we plot the case where the models fit using only the covariates X. And the second row is a case where the models fit using subgroup membership as an additional covariate. And the final row is a case where we fit a separate model for each subgroup. So in general, these results correspond to what I've described so far. We see that when we use only the covariates for prediction, our model satisfies sufficiency only when the covariate shift assumption holds and when the data is separable, but violates sufficiency in all other cases due to subgroup miscalibration. And when we use subgroup membership for prediction through either approach, we do get sufficiency. And so we can also take these settings and sort of measure the impact of, or rather measure the informativeness of subgroup membership on the performance of the model. And so here, what's plotted is the differences between the performance of a subgroup aware model versus the performance of a subgroup agnostic model. And so like a negative value of the log loss on the left plot would indicate that the subgroup aware model actually performed better than the subgroup agnostic model. And so here what we can see is that this is actually the case for all settings except covariate shift in the separable case, similar to what I showed you for the calibration curves. And you can see something similar for AURSC. I also want to point out that the sensitivity and specificity can sort of change in either direction. And the direction of the change in one often sort of corresponds to a negative change in the other. However, we can sort of see that if we look at net benefit, which combines the two metrics, the results of net benefit are sort of directionally similar to what we observe for the log loss. And so one way that's kind of useful for thinking about this is to think about this as a lack of performance metric stability due to confounding across groups. And so to build on this, we can sort of consider performance metrics to be functions that depend only on sort of the model predictions R and the label Y. And so what this means is that if the distribution of the predictions R and the outcomes Y are the same for all groups, then performance of all groups must be the same for any performance metric because the performance metric is just a function of those two variables. And so this property is kind of encoded in the second bullet on this slide. And one thing to notice is that this statement of statistical independence is not actually true for any of the DAGs on the slide. Meaning that in general, the performance of predictors, be it arbitrary ones or optimal ones, are not constrained to have equal performance just by the structure of the graph alone. And again, this doesn't necessarily imply that performance is different, just that it's not necessarily the same. And so we can consider an extension of this condition that allows us for reasoning about sort of conditional differences across groups. So for some intuition, in the covariate shift case, you might think that performance is conditionally equal after conditioning on X if the predictor is subgroup aware, because if we condition on X, we sort of control the distribution of the prediction and of the outcome Y. And so conditioned on X, performance is the same across groups. And so under the label shift graph, you can also make sort of a related claim by conditioning on Y, in the sense that conditioning on Y controls the distribution of X and of Y, and thus of R for the subgroup unaware predictor. And so you can kind of extend this analysis to reason about the effects of controlling for different variables in these different graphs under different assumptions on the model. So in the table, these check marks corresponds to cases where a particular variable set is sufficient to control for any difference in a performance metric across subgroups for each of the causal graphs and for different assumptions of the model. And that's assumptions on whether the model is optimal or whether it's arbitrary and whether it's subgroup aware or not. And so while there's a lot here, I'll draw your attention to a few key points. So we can see that if we look at uncontrolled evaluations, which is the case where we're sort of looking at the leftmost column of marks with the empty bracket, we can see that performance is not constrained to be equal in any graph, as I mentioned before. And when we control for x, we expect that sort of controls performance differences in the covariate shift graph. And when we control for y, we see that controls for performance in the label shift graph. And then in both of those cases, only for the case that prediction depends on x. And then one other thing to note is that if you control for the distribution of the prediction itself, so you imagine looking at the distributions of predictions and then sort of balancing that distribution across subgroups, you can see that this actually corresponds to a test for sufficiency in the sense that violation of, or rather differences in performance after controlling for the score sort of correspond to violations of sufficiency. And so we can actually use, we could potentially consider a set of complementary evaluations that actually control for the different sources of confounding. And the main idea here is that you would like to balance the distribution of some control variable v across subgroups, maintaining the conditional distribution of other variables conditioned on v. And so intuitively, what we're doing here is sort of reweighting the entire population distribution to match each of the subgroups and doing this separately for each subgroup. And you can actually just do this with weights that are proportional to of the probability of A given B. And then you can compare the weighted population performance to the subgroup performance separately for each subgroup. Interestingly, this corresponds to a conditional dependence test against the null hypothesis that corresponds to that conditional dependence statement I showed in the previous slide. And so this interpretation actually allows you to view control for x as a test for violation of the covariate shift assumption, and control for y as a test for violation of the label shift assumption, and control for r as a test for sufficiency, as I mentioned. And so here's what you get if you apply this approach to the set of simulated examples I described earlier. And so here, what I plot are the differences between sort of that mapped population log loss and the performance on the subgroups in an unweighted sense. And so again, the first row is sort of a population agnostic model. The bottom row is a subgroup aware model. And each column corresponds to a different setting on the weights. The first column is just the unweighted comparison, which shows that there's some difference in performance between the performance on the whole population and the subgroups. And then when you control for x, you see that this difference in performance is 0 in both the covariate shift and the separable case, but not others. When we control for y, we see that we do get sort of equal performance under the label shift graph. We see that it does actually limit some differences in performance under the covariate shift graph and the complex causal graph. I'm not showing these results here, but when you look at sort of a broader set of metrics, you see that control doesn't apply to all metrics. And when we control for R, if we interpret this as a sufficiency test, we can see that this is consistent with our expectations in that when we control for R for a model that only uses X for prediction, we get sufficiency under the covariate shift and separable case. And then when we use subgroup information in the prediction, we see that we get sufficiency in all cases. So I want to mention a few major challenges to interpreting these evaluations. And so the first is that these procedures can't really tell the difference between cases where where performance differs across groups due to failure to fit the data well for some groups, from cases where there's some difference in performance of a model that is optimal or close to optimal due to sort of structured differences in the distribution. In other words, these evaluations can tell you when there's heterogeneity in the error across subgroups after conditioning on a confounder, but they cannot tell you what portion of that error is sort of fundamental to the data distribution versus components that are due to failing to model the data distribution. And so, for example, if the covariate shift assumption holds, it's true that if you control for X, you would actually return equal performance for any subgroup agnostic model, even one that sort of doesn't actually fit the data well. And so it's important not to use these procedures to explain away differences in performance that are due to underfitting the data distribution. Also mentioned that really choosing the right control variable and interpreting it appropriately does require understanding the context that generates the data. And I think this is relatively clear if you think of as the covariates that you might consider controlling for the other variables as proxies of disparity. And it's not entirely clear what are the best practices for using and interpreting these, given that that's the case. So I'm going to shift gears now from, let's say, the next 10 minutes. And so until now, we've largely assumed that our training population is representative of a target population. And as I mentioned earlier in the talk, this is typically actually false due to the interaction of social and structural determinants of health with things like selection, measurement error, label choice, and related issues. And so I'll now discuss how these factors affect evaluations. And so to summarize a few key points, in general, we can think of these biases as inducing evaluation data to be differentially misrepresentative across subgroups. And one way to think about this is if you applied the type of fairness violation or the type of analysis I've described thus far to this data, you would end up with, or rather, if you fit the data well, you would end up in a setting where there is fairness violation sort of in the, let's say, the unobserved target population, and you can't detect it without additional information. And that might be through further data, some form of causal assumptions or domain knowledge. And I think sort of despite broad awareness of this general problem, there really are few analytic tools for understanding it. And these concerns are distinct from things we've discussed so far. And so first, I'll discuss selection bias. And so the main thing to take away here is that we can adapt the causal graphs that we presented earlier with the selection node, which is the square node marked with an S. And so these graphs capture different assumptions about which of the variables affect the mechanisms through which samples enter into the data set. For example, if we have just one arrow coming from A into S, it would be a mechanism where different groups enter into the data set at different rates, but this process would depend only on group membership and no other variables. And so in that setting, it would actually be appropriate to think of each subgroup as representative of that subgroup, even if the overall population is sort of not the same distribution as the target population. And so as before, we can use the structure of the graph to reason about the expected properties of models. And one sort of useful property is that we can think about the model as sort of generalizing to the target population under selection if the covariates deseparate Y from S. So for example, if selection depends only on X in the causal direction graph, then a subgroup agnostic Bayes optimal model would generalize to the target population. And so there's a lot of potential results here. I'm not going to get too into the weeds here, but we can extend this type of reasoning to sort of a rich set of properties in the way that I've talked about before. And so here we're looking at calibration with a graph that has the complex causal shift structure and with a mechanism of selection that varies across the different columns that are plotted. And so what we're doing is we're fitting a model in our observed selected data and then evaluating it in the true population that we don't observe. And what we can see is that when that selection depends on X, X alone, the model actually behaves as we would expect it to with respect to calibration, in the sense that the calibration properties in the observed data match those of the target population. When that selection depends on Y, what you see is sort of a global shift in calibration. And so when we're doing subgroup aware prediction, we'll see that we end up with satisfying sufficiency, but sort of a model that's globally miscalibrated. But when that selection depends on both Y and A, you sort of end up with both miscalibration and sufficiency violation. And so that's all I'm going to say about selection bias for now. I want to talk a bit about label bias with biased proxy labels. And so we'll say that a proxy label is biased if our optimal prediction of it implies differential miscalibration. That would be violation of violation of sufficiency with respect to some true label of interest. And this is kind of an example of that masking of fairness violation in the observed data. And so a good example of this is this example from Ziad-Obermeier's paper in Science in 2019, which I'm sure many of you are familiar with. But in the study, they analyzed an example of a machine learning system used by large health systems and insurers in the United States for high-risk care management, where the goal was to identify patients who are likely to have complex healthcare needs so that they can be enrolled in care management programs. And the intent of this system was to output a score that reflected the healthcare needs of patients such that greater values for the score imply greater potential benefit through referral to care management. So a challenge here is that it wasn't actually clear how to formulate a supervised learning problem appropriate for the setting because the ideal label of complex healthcare needs is unobservable and thus needs to be operationalized with a proxy label. So in this instance, the algorithm developer chose to predict healthcare expenditure for each patient, which is essentially the amount of money that the healthcare expenditure or the healthcare system spends on each patient. And so the assumption underpinning this choice was that patients with greater healthcare expenditures have greater healthcare needs. And so, as you can imagine, this assumption is problematic because it's only valid if patients who need healthcare are able to access it. So, if we were to compare two patients with the same level of healthcare needs but different levels of healthcare access, we would expect to observe greater healthcare expenditure for the patient with greater access to care. And so this is particularly relevant to reasoning about racial health disparities in the United States because of substantial evidence of forms of structural racism that systematically limit access to healthcare for Black Americans relative to other groups. And so what impact does this choice of label induce? So on the left, you can see what actually is analogous to a calibration curve of the model in terms of its ability to predict medical expenditure. And this plot shows that the model apparently satisfies sufficiency due to overlap of the curves. On the right, you can see sort of an analogous evaluation of that same model where they fit it with respect to an alternative proxy of healthcare needs that is based on a measure of comorbidity, essentially counting the number of chronic conditions recorded for each patient at the time of prediction. And so here we can see that for any threshold chosen, the Black population has a greater number of chronic conditions than the white population, which can be interpreted as a form of racial bias because it implies different implicit thresholds of referral, such that Black patients essentially need to have greater healthcare needs than white patients in order to be referred into the program. And if you recall, this is the notion of fairness in decision making that I mentioned earlier in the discussion of sufficiency. And so as a part of, I'm just going to go through this briefly, as a part of our FACT 2024 paper, we sort of aim to build understanding of problems like this by sort of augmenting our causal graph approach to incorporate proxy labels. And so you can think of Y as our sort of unobserved, our unobserved label of interest that we're interested in reasoning about, but that we've measured some biased proxy of it, or rather we've measured some proxy of it. And so on the left-hand side, we might think of Y1 as an unbiased proxy, and on the right-hand side, Y1 as a biased proxy. And so here, this sort of backdoor red bidirected edge between A and Y effectively encodes the intuition that Y1 sort of means different things for different subgroups. So in the context of our example from the paper, Y1 would indicate healthcare expenditures, but there's some systematic difference in healthcare access across groups that influences sort of the way that we observe Y1 beyond sort of its relationship with Y. And so our core results kind of connect the causal structures to the ability to infer fairness properties with respect to the true label using the proxy label. And the main thing we're getting at here is essentially saying there's some set of settings where it's valid to reason about violation of sufficiency or satisfaction of sufficiency using a proxy label and sort of translate that into reasoning about sufficiency with respect to the sort of unbiased proxy of interest. And so the main thing to note is that if we assume sort of that we have an unbiased proxy, so for example, in Ziad-Obermeier's paper, they assumed that the comorbidity index was an unbiased proxy. You can actually use violation of sufficiency with respect to that unbiased proxy to claim sufficiency violation with respect to the ground truth unobserved. And then similarly, you can sort of show that fitting the biased proxy, or rather fitting the data well, where by fitting the data well, I mean sort of fitting the biased outcome, sort of results in sufficiency violation and fairness violation for the unobserved true outcome you're interested in. And so we actually played around with this using the data released by the authors of that paper, and also showed that sort of fitting these subgroup specific models actually sort of induce sort of additional bias in terms of exacerbated sufficiency violation with respect to the unbiased proxy, which is some analysis that was not in the original Obermeyer paper. And so to close, I hope I've convinced you that evaluation of simple models is highly nuanced and requires understanding of context. The approaches that I've discussed today, while broad, I think still actually adopt a somewhat narrow lens centered around thinking about models as simple like threshold-based interventions. And it's also important to also consider like interventions that don't look like this at all, that target upstream structural causes of inequity. But ultimately, I think the main takeaway is that we need to evaluate AI systems in the socio-technical context in which they're intended to be used, and emphasize participatory, equity-focused measurement when we do that. So I'll stop there, and maybe we have a few minutes for questions.
Thank you so much, Dr. Thornton. I'm going to see if anybody wants to jump in for questions quickly. So I won't ask a question as I normally do. So feel free to put your hand up, unmute yourself, write in the chat, whatever you want to do. It was a really good talk and very comprehensive. Thank you, Stephen.
Oh, thanks.
Will you be at FACT this year?
Unlikely, because I basically don't have travel funding.
Disappointing. Are there any questions? I know we're very close to time, so I won't keep everyone, but please don't be shy. Okay, great. Well, I will wrap up just because we've only got 3 minutes to go, but that was really interesting. Thank you so much for joining us. I will make sure the recording is available, and if you have any questions, please get in touch with Stephen, who's very kindly provided his email address. Yes, we will see you for the next month's webinar. I'm sure details will be sent around. I actually can't remember the date off the top of my head. But thank you so much, and thanks for joining, everyone.
Yeah, thanks a lot.
Thank you.
Bye.
Bye.